Next session will be about question number 11 to 14, that is on indications and contraindications of reoperation. I would like to welcome Chairperson Dr. Anand Nagar, who is Associate Professor in the Department of HPB Surgery at mgmch, and Dr. Tseten, who will be joining online from Nepal. He is a Senior Consultant at Kathmandu Medical College.
So I would like to invite for this session lead presenter Dr. Murugappan. Dr. Murugappan is working as a consultant at Hyderabad. Dr. Murugappan working as a consultant in Shastra Hospital, Bangalore. And I welcome Dr. Tseten. She's joined online.
Good morning, everyone. I've been tasked with the discussion of indications and contraindications of re-resection in IGBC. So to begin with, we did a literature search using this research query, which we try to include almost all of the possible papers, with including gallbladder diseases with a Boolean operator and an incidental findings. So this is what we found when we looked at PubMed. The number of records that were obtained were 678. After excluding case reports, editorials, technical reports, reviews, and non-English language, we were left with 183 papers. The abstracts were screened of these. After the abstract screen, we were left with 131 papers for full text screen. 21 of them we couldn't retrieve. 72 had no relevant data or data discrepancies, unclear data, or they had combined data of a diagnosis where an intraoperative diagnosis was made along with a postoperative diagnosis. So at the end of it, we were left with 38 studies. So the following thing will be on these 38 studies. So I've put up a series of tables. I've tried to maintain the commonality in these tables with the year and the author mentioned initially, then the number of IGBCs here, the disease which the topic of discussion, the management option, the survival outcomes. I'll be going a little fast with these tables. This is for your to get accustomed to it. So the coming to PT1A, the first thing, there was just one registry, German registry, which had offered an extended resection for these patients. It compared extended resections with the simple cholecystectomies in these patients, and they found that there was no survival advantage. All the other studies showed that the 5-year disease survival was roughly in the tune of around 100% in these patients, suggesting that a simple cholecystectomy is a sufficient surgery for these patients. Coming to PT1B, again, most of them are from the registries where they were treated with extended resections versus simple cholecystectomy. There was a comparison. The extended resections provided an improvement in survival. However, they were not found to be significant in any of these reports. PT2, again, extended resections and versus simple choles. So many more number of studies, more number of patients, except and an extended resection showed better survival in almost all of these studies, which didn't reach significance in 2 of these reported. Coming to PT3, all of them were from again national databases, and there was a survival advantage in most of these. PT4, ideally we shouldn't be encountering PT4. Exceptions were discussed yesterday, where when once surgery is being done for a complicated gallstone disease, one might encounter these. So the case reports that have been mentioned are few and far between, so and all of them universally have dismal prognosis reported. Coming to the next risk factor, this is the tumor grade. The following studies have reported on the grade, G1 being well differentiated, G3 poorly differentiated. G3 disease or the poorly differentiated disease is shown to have higher odds of having residual disease, more higher odds of having residual disease, more distant residual disease, and consistent poor survival in these patients, which is significant. Lymphovascular invasion was the next risk factor, study which had 15 patients of IGBC, 10 of them had lymphovascular invasions, 9 of these 15 were re-resected. So in the group of patients who didn't have the lymphovascular invasion, that is 5 of them, 2 didn't undergo any re-resection. They didn't have the number I've put in the brackets, the mortality. They didn't have any event up to 5 years of follow-up. In the patients who underwent extended resection, there was one patient who had a mortality event. In the 6 patients with LVI present, of the 10 patients, 6 patients with LVI present underwent extended resection. 2 of these had a mortality event, and the extended resection had in fact increased the survival to more than 2 years in these 2 patients. And of the 4 patients who didn't have extended resection, 4 patients of LVI who didn't have extended resection, all 4 of them had a mortality event within 2 years of diagnosis. So they predicted that it's an indicator of prognostic indicator of a mortality event. Similarly, another report with 59 IGBC patients, the reported lymphovascular status were 15 positive and 32 negative. The residual disease with respect to lymphovascular invasion, there were 11 of the 15 patients who had positive, residual disease. 10 of the 32 had, and this was found to be a significant prognostic indicator again. Perineural invasion, again is the same paper which had 59 IGBCs. They had reported 16 positive cases and 19 negative cases. The residual disease seen in them were 11 of the 16 patients with positive perineural invasion had residual disease, and 5 of the negative cases had residual disease. Again, this was found to be significant. Coming to the next factor, which is the cystic lymph node, this group did a registry study with 73 patients of cystic lymph nodes were retrieved. 29 were positive, 44 were negative, 114 were the other unknown group. A positive cystic lymph node meant there was more PNI, more LVI, higher incidence of residual cancer, higher likelihood of cancer in the lymph nodes, increased recurrence, and higher likelihood of positive hepatic pedicle lymph nodes. They didn't find positivity in the N2 nodes, but they did find positivity in the N1 group of nodes. However, this is currently with the number of nodes being more important, but this is what they found at that time. And this meant that there was a worse disease specific survival in these patients with positive cystic duct lymph nodes. The same group looked at the cystic duct margins 2 years later. They found that of the 179 patients, 33 patients had margin positivity at initial cholecystectomy. They had resected 42 of their 179 patients. A positive cystic duct margin meant that the 5-year survival was poor. A CBD resection did not improve the survival. It increased the morbidity. However, if on extended resection no residual disease was found, still the cystic duct margin meant an independent predictor of poor overall survival, but a CBD resection in these patients provided a survival similar to a cystic duct negative group, but when a CBD resection was not done, the disease survival was poor, significantly poor. Coming to the incidence of residual disease, the discussion that's been spoken of since morning, these are the papers which have reported based on the T stages of these tumors. So roughly the incidence in T1B is around 20%, extending from 0 to around 20%. T2, it goes up to the tune of 60 to 68. T3, it is around 80%, and finally in T4, all these patients, most of these patients had residual disease. So what is the impact of residual disease on survival? Again, the thing that's been discussed from morning, most of them uniformly showed that there is decreased survival with the presence of residual disease. I would like to bring your attention to these 2 papers. The one which was discussed yesterday, the paper by Duffy et al. The median survival with no residual disease was 72 months. Where a residual disease was found and an R0 resection was achieved, it was 19 months. A residual disease was found, no R0 resection, it reduced further to 12.7 months. Similarly, a report again from I think from the US itself, 3-year survival, disease specific survival, that is 64% for extended resections without residual disease. In presence of residual disease, it comes down to 30. In presence of residual disease, if no resection is done, it reduces to 8%. The next and the final factor, that is the bile spill. There were around 20 papers which discussed bile spill. as a factor. However, most of them were one-off, special one-off mentions. These are the papers with significant numbers reported. All of them universally reported poor, all these surgical outcomes that were reported were significantly worse in patients with bile spill. Just skip this slide, the bile spill is associated with increased likelihood of finding residual disease, finding distant peritoneal disease, and lesser chance of curative resections. So I would like to leave with this final slide. So for patients with T1A, ideally we would observe the presence of cystic duct margins, cystic lymph node positivity, LVI, grade 3, bile spill. This is the gray zone. T1B, you would again re-resect because the possibility of finding a residual disease in the tune of 20%. Resection of a residual disease found to be better than leaving it alone. T2, T3, resect after metastatic workup. However, these in presence of an LVI, PNI, grade 3 disease, bile spill, we would, what's been discussed now, try to do an extensive workup and consider neoadjuvant therapy in them. A delayed presentation in these again is a gray zone. T4, so you would individualize treatment for these patients. So I would like to end it with saying that we should have a predictive score for the finding of residual disease in these patients, which should also even help us in coming up with our workup strategy. Thank you.
Thank you, Dr. Murugappan. For the comments, I would like to invite Professor Yoji Kishi. He is a professor in hepatobiliary pancreatic surgery, National Defense Medical College, Japan.
First of all, I'd like to express my sincere gratitude to Professor Kapoor and his colleagues for the kind invitation and the great hospitality here in Jaipur. It's my honor to have this opportunity to make some comments on the clinical question of the indication and contraindication of reoperation for incidental GBCA. I'm from Japan, and in our country, recently the third edition of guideline for the treatment of biliary tract cancer was published. But in this book, there is only one clinical question regarding the treatment of IGBCA. That is, should resection be performed for pathological T2 or more incidental GBCA? And the answer is resection at the same time or afterward is recommended. The recommendation grade was 1. So let me introduce our own experience for the last 3 decades, which including the rather old cases. We could identify 21 cases of incidental or missed gallbladder cancer for the last 3 decades, which accounted for about approximately 3% of all cholecystectomy cases in our institution. The median age of the 21 patients was 70 years old, and the distribution male and female were almost half and half. The main etiology was cholecystolithiasis, gallbladder stones, followed by acute cholecystitis. Bile spillage during the index cholecystectomy occurred at least in 3 cases, and resection was performed in 17 patients, which accounted for 81%. And the final pathological staging was mostly the T2 and T1, and the T3 patients accounted for about 1/4. Only 5 patients were found to have lymph node metastasis, and the number of metastatic lymph nodes was only 1 or 2 in most cases. This is the outcome of the 4 patients who did not undergo resection after index cholecystectomy, mainly due to the early tumor stage with T1 stage disease or physical conditions, mainly due to the patient's elderly age. Of course, the patient's advanced disease with T3 or bile spillage in the first patient died of the disease. On the other hand, 70 patients underwent resection with after the median interval of 34 days after the index cholecystectomy. Again, T1 and T2 accounted for the 3/4 of the total population, and T3 for the 25%. The main procedure as a resection was the hepatic vein resection and lymph node metastasis and lymph node dissection with and without bile duct resection. Only a few patients underwent WIP procedure due to the extensive disease along the hepatoduodenal ligament. And of course, there's a big difference in the prognosis between the patients with and without residual diseases, like this. None of the patients, 10 patients without residual disease died of gallbladder cancer. On the other hand, only one patient here is T2 and one disease with residual disease in the stump of the statistical duct could survive for as long as more than 10 years. As a whole, the 5-year survival rate with and without residual disease was 70% and 86% respectively. This is survival according to the pathological stages. Of course, the patients with less advanced disease showed better survival, but T3, the patients with T3 or non-positive disease, also in certain proportion of such patients could survive for a long time. So these patients should not be contraindicated for resection. As Dr. Murugappan presented, there are many papers that evaluated the outcomes of resection, mostly the retrospective cases, and only a few studies were evaluated with a large series. This is a paper from Netherlands using the National Cancer Registry, and 102 resection patients and 353 patients without resection were compared. Of course, the patients with resection showed better survival as a whole, and of course, the patients without residual disease showed significantly better survival. But it should be noted that only about approximately 10% of especially T1B or T2 disease had residual disease finally. This is another paper from Chile and the United States, M.D. Anderson, which also evaluated the outcomes of resection. Among the totally 187 patients, residual cancer was not recognized in more than half, 102 patients. And of course, no residual cancer was showed significantly better survival compared to those with residual cancer in the total population and in the subgroups of stage 2 or stage 3 respectively. This is another paper from Sweden using national cohort, and 92 patients who underwent resection among 249 patients with incidental GBCA were evaluated. Again, no residual tumor was associated with better survival. And the multivariate analysis for disease-specific survival showed that only the residual tumor, rather than pathological staging, was an independent progress factor of disease-specific survival like this. Also, the site or extent of local residual disease could be an important factor to predict prognosis, as several papers described. Like this, the limited residual disease could be associated with better prognosis. So, in my opinion, we do know that in the patients who received resection, residual cancer could be a significant factor that predicts fast prognosis. But one question is resection should be mandatory in the whole patients with esophageal cancer. These certain proportion of patients could have received over surgery. And on the other hand, as most papers shown, esophageal cancer was definitely a predictor of worse survival, and mostly showed very dismal survival was shown. So resection only will not be enough, and some multidisciplinary treatment could be expected, I think. And on the other hand, among the patients who had been actually followed up without resection, potentially certain proportion of patients could have residual diseases. And these patients should have been received resection. So the discrimination of potential residual cancer could be a problem. This paper has been mentioned yesterday by several speakers, which proposed a predictive risk score of residual diseases using T-stage, tumor differentiation grade, vascular invasion, and permeable invasion. Such score could be help distinguishing the patients with or without residual disease in the future, but it could not be perfect. So let me introduce finally our most recent really experienced very regretful case. The patient was 77-year-old male. Preoperatively, we did not at all suspect the possibility of gallbladder cancer, and under the preoperative diagnosis of gallbladder stones, we performed RAPC. But due to severe severe adhesion around the gallbladder neck, incidentally, the bile spillage occurred, and the conversion open cholecystectomy was performed. And only after pathological evaluation, the gallbladder cancer of T2 was recognized. So what we did was a delayed resection because we are afraid of tumor dissemination due to bile spillage. This PET scan performed only after 1 month after initial cholecystectomy, which did not show any sign of distant metastasis. And now the patient has been receiving oral chemotherapy with S1 for about near half a year, and we are wondering when to take this patient to the operation room for the resection. So this is my final slide. There are several questions or issues that should be addressed. First, although we did not focus on this issue, the interval until resection is still a controversial issue. Yesterday, many discussions mentioned that median or long interval for more than 4 or 8 weeks would be feasible than short interval after index cholecystectomy, probably due to it enables accurate staging and less effort in adhesionectomy would be required. Second, strategy according to TMS stage or location of residual tumor should be mandatory, but I think there is room for resection for advanced disease even in T3-4 or node-positive diseases. And lastly, this would be discussed in the later session, but pre and post resection additional treatment could be an expected issue in the future. Thanks for your kind attention.
Thank you, Professor.
This one.
For the next comment, I would like to invite Professor Kun-Ming, maybe online videos.
Hello everyone, my name is Kun-Ming from Tamang Memorial Hospital at Linkou, Taiwan. Our hospital located in northern Taiwan, and it also has the largest medical service in Taiwan. It's my honor to be invited to participate in this meeting for the International Study Group of Breast Cancer. I'm sorry that I could not attend this meeting on site, so I would like to express my appreciation to the organizing committee and chairman, as well as all the participants at this meeting. I am sure that this international study group of consensus meeting regarding global cancer will provide us most updated information in terms of management of global cancer. I am responsible for question 12, that this 12 has two sub-questions. 12A is in which cases with incidental global cancer, reoperation is not required, that we only need observation and the follow-up alone is enough. I think if the patient tumor stage only T1A that only limited in lamina propria, not beyond T1A, and during operation there is no biospillage and the global specimen is intact and complete, and also has no 60 lymph node involvement. And I think this kind of patient can be only observation and follow-up alone is enough. On contrast, if the tumor beyond T1A, which is T1B, there might be need further radical operation for these patients. And 12B is observation and follow-up alone enough for T1B, that the tumor involved muscularis propria, incidental global cancer, yes, in which cases. And I think the most important thing is 60 lymph node involvement. If the patient has the tumor located at the peritoneal site, and also the 16 node negative and the 6 margin negative, for this group of patients with T1B global cancer, they might be can only follow up or observation is enough. However, reoperation will be benefit for tumor staging that has lymph node invasion. Meanwhile, we also can use some predict risk score as a tool for evaluating reoperation for patients with T1B incidental global cancer. However, we also need to concern about the patient's physical status. That means that we need to concern about the perioperative mortality associated with radical resection. Is my responsibility of the question 12. Is welcome to give us some comment, or we can discuss in the discussing session. Thank you.
Kapoor Festival. It is my honor to be part of this Congress. Today, I express my point of view about the indication and contraindications of reoperations in incidental tumor. Before deciding on the therapy, the most important fact is to know the exact level of wall invasion. This slide shows the different possibilities of invasion of the therapy. All patients treated. Survival at 5 years is higher than 95%, and the patients must be considered already treated with cholecystectomy. Patients with a T1B tumor, the invasion reaches the muscle layer. This slide shows a typical gallbladder cancer with an invasion of the muscle layer. For this group of patients, there needs to be a clear recommendation. These slides show the author's different positions concerning the management of these patients. In our center, we have studied a large number of patients with T1B tumors, and there is no difference between those who underwent resection and those who underwent only cholecystectomy. In the same way, the number of patients with lymph nodes or liver invasion in these patients is extremely low. From now on, and based on the results obtained in our center, we will not operate on patients with T1B tumors. In T2 and T3 patients, the recommendation is to reoperate the patients. There is a consensus to adopt the above recommendation. What about the contraindications for resection? Before operating on a patient, we must study possible dissemination using images. Although there is no consensus, PET-CT could be helped to discard distant compromise. Due to the cost of PET-CT, triphasic CT is a good alternative. In my opinion, the compromise of lymph nodes number 8 and 9 should be a reason not to proceed with the reoperation. The compromise of the number 13 lymph node is a matter of debate. The next station from the number 13 lymph node is the retropancreatic lymph nodes. By lobar or massive liver infiltration and invasion of the vascular structures of the hepatic pedicle, randomized trials support the value of reoperation in incidental tumors. Most papers show a difference in survival between patients who underwent reoperation versus those who underwent only cholecystectomy. However, the groups are different and not comparable. Patients who underwent reoperation and resection were already staged and selected. In these patients, we know the absence of distant or local compromise before the surgery. On the contrary, we do not know the exact level of dissemination in those who underwent only cholecystectomy. Unfortunately, due to the low incidence of this tumor in the world, it is difficult to get a randomized clinical trial. Another critical topic is the value that neoadjuvant chemotherapy or chemoradiotherapy could have before operating the patients. Currently, a couple of clinical trials are in the recruiting phase to answer the above. Thank you very much.
Can we show the online Professor Tseten is connected?
Namaste from Nepal. There is substantial evidence for us to suggest that T1A disease do not require reoperation, whereas T2 disease or more benefit from reoperation unless the patient is unresectable or patient is vulnerable. Much controversy exists in T1B disease. If you see here, the overall survival ranges from 37.5% to 100% after cystectomy. After radical resection, there is varying results, some showing benefit, others showing. Before we consider T1B disease, I think it is important to understand the controversy that exists with T1B disease. The fact that there is diversity in literature, which means that most of the T1B disease is either clumped with T1A disease or T2 disease, when it's reported, has to be considered. Second, we know that there is difference in incidence of carcinoma gallbladder, of T1B incidental gallbladder carcinoma per se, Eastern countries as well as Chile showing less incidence compared to West. This could be because of the fact that there is difference in histopathological study of the cholecystectomy specimen. Studies reveal that 29% of PT1B disease reported after random sampling focused on gross abnormality were actually T2 when comprehensive mapping protocols were used. However, there is a possibility that some T1B disease are actually better than the others. And there could be various factors which actually might differentiate a bad T1B disease from a good T1B disease. We know that lymphovascular and perineural invasion can occur in about 33.3% of cases. They're both associated with high incidence of locoregional disease and distant disease. node positivity can occur in 10 to 20% of cases. We know that in simple cholecystectomy, a lot of nodes must be undetected or neglected. And we know that when cholecystectomy is only performed, the disease-specific survival and overall survival is less compared to when lymph node dissection is done. And if radical cholecystectomy is done, disease-free survival and overall survival is better. We also know that poorly differentiated gallbladder carcinomas behave poorly. They have early recurrence and survival is poor. And you can see here that when grades are high, local regional disease and distant disease are both high. And with resection margin, we know R1, R2 have poor prognosis, whereas R0 is associated with better prognosis. In fact, these factors have been combined into a gallbladder cancer predictive risk score, which stratifies incidental gallbladder carcinomas into low risk, intermediate risk, and high risk group. Now, intermediate risk group has a local regional disease incidence of 24%, and the chances of distant disease is 3%. And studies reveal that 78% of T1B disease have intermediate risk, which means that they benefit from operation. Now, there are studies to suggest that bile spillage is associated with high incidence of distant disease and local regional disease. Now, distant disease is more common than local regional disease, and we know bile spillage is associated with both shorter disease-free survival and shorter overall survival. Fortunately, local regional residual disease is more common than distant disease with T1B disease. 17% is the incidence of local regional residual disease, and when it's present, the overall survival is 20.7 months. Now, the problem with residual disease is it is very difficult to identify it before the surgery. The imaging modalities do not help much. PET seems to be of some benefit because some study shows that when it's PET positive, the prognosis is poor, but we also know that it is subject to misinterpretation because post-operative inflammation can also lead to PET positive. Now, I did show that articles conflict in terms of the result after reoperation, but this is a decision analytic Markov model study done by Abramson et al., and which showed that if you consider other factors, the post-operative factors, simple cholecystectomy is inferior to radical resection in terms of disease-free survival and overall. So I believe that if there is lymphovascular invasion, perineural invasion, if it is poorly differentiated, the nodes are positive, it's R1, R2 resection, it has to be reoperated. We need to avoid bile spillage as far as possible. PET positivity at the moment seems to suggest residual disease and therefore probably necessitates reoperation. Thank you.
So regarding the question in which we are discussing, our whole topic is indication and the contraindication of reoperation. If we discuss the definitive contraindication of the reoperation, then rest of we can consider these are the patient in which we should go for the surgery. So I want to ask from the house, in which cases we'll definitely will not go for surgery or not go for reoperation. Sir, your opinion.
My job is to raise questions, not answer, so I will raise the question.
So I will ask from the faculties
So
or the senior
I'm raising
faculties.
a very specific question. T1A, but histopathology from some other center, just a one-line report, adenocarcinoma, T1A. No other information available. We don't know whether bile spill occurred, bag was used, or whatever happened during surgery. What would you do? Biju.
Sir.
Shiven, reoperate. Sadek, T1A, a very cursory report from some pathologist whom you don't know, no surgical details available. No blocks available. Puneet, PET, okay, you have done PET, negative, yes. No distant disease, there is some avidity in the fossa, some avidity in the regional nodes, as Biju said. So what I'm saying, T1A with no complete information, a very cursory pathology report, because it has been shown, and I think Sumaira yesterday commented that if you see an incidental gallbladder cancer, ideally you need a mapping of the gallbladder, because at some other place it may be T1B. So what I'm trying to emphasize, T1A, very not a reliable or not a known source of pathology reporting, no surgical details available. We don't know where the tumor is, what is the cystic duct margin, no other information. What would you do? So that is what I said in the suggestion, that in my opinion, the only situation where I would not reoperate is T1A, no bile spill, reliable pathology, cystic node was in the specimen and is negative, and cystic duct margin is negative. This is an ideal world. And PET CT, of course, negative. Shaleen, so the situation given by me? Sir, in real life, if you ask a surgeon 7 days ago who's doing 5 cholecystectomies a day, who doesn't keep any operative record. Yeah. Tseten, what is your opinion? Can we have Tseten on the screen, please? So in this situation, because that is the real life situation in incidental gallbladder cancer. Most cases you don't have complete information.
First of all, thank you for having me participate in this program. I'd like to thank you and congratulate you as well. And at the outset, also apologize for not being able to be there physically. And I think to answer the question, I think obviously it's a hypothetical question, and a lot of things are in doubt, and a lot of caveats, and a lot of, if in doubt, I think it is more to be on a safer side and to reoperate.
Okay. Now the other situation, T2, or sometimes as it happens T3, all reports of incidental gallbladder cancer include T3, although ideally it should not be there because a good imaging should have detected a T3 lesion. But again, the real life situation is that T3 also comes as incidental, whether it is true incidental or not, that we have discussed yesterday. So T3 or T2, PET scan or CT scan, whatever we have done, shows beyond regional, that means para-aortic nodes. What would you do? Tseten,
Sir.
you first.
So the para-aortic nodes are positive. Is that the scenario, sir?
Yeah, either they are enlarged on CT or they are showing some avidity on PET scan.
I think then any benefit with neoadjuvant chemotherapy before a reoperation should be considered.
Anand?
Sir, we'll consider these patients like metastatic disease, M1 disease. So if we want to try and put confirmation of diagnosis, EUS guided biopsy of this FNAC of these nodes, and we'll consider these patients as M1 disease, metastatic disease.
No, so suppose
Yeah, we'll
FNAC is positive, what would you do? Suppose FNAC is
We'll consider, this is a metastatic disease, we'll give palliative chemotherapy only. We'll
and
not
if
open.
FNAC is negative?
Then we can,
Shiven wanted to say.
If your leg para-aortic is there, then definitely you go do a FNAC or intra-aortic level. If it is positive and there is no other site, what our philosophy is to give a neoadjuvant chemotherapy. If there is good response, even resecting in these group of patients will have a much better survival as compared to metastatic. If the only site is aortocaval lymph nodes. This we have published our experience also for it.
So that is very interesting debate. I am medical oncologist. I think I am the only, or somebody might be there. But that is very interesting that you give neoadjuvant chemotherapy in such situation where there is doubt. At least we will have the idea about the biology of the disease, that how aggressive the tumor is. If the tumor shows good response, even that will give to like better disease-free survival or overall outcome. May not be cure, but at least good survival outcome may be there with this approach.
So although it is not the theme, but Shivendra, I will ask you, primary GBC, para-aortic node, CT, you've done an FNAC, it is positive, you give neoadjuvant. Now, do you look at, after completing a neoadjuvant, do you look at only the anatomy? That means this nodes have reduced in size or disappeared, or again you will do an FNAC to make sure that they have become negative before you go for reoperation? For operation?
We will not do the repeat FNAC if there is a response is there and there is no progression of the disease, and we don't need extended resection like SPD or major liver resection. Only simple radical cholecystectomy is required, then we'll go ahead and operate.
You do a para-aortic lymph node dissection.
Complete para-aortic lymph node, all stations 16A, B, C, D, both, all we do, all 4.
That is, now that means that we are challenging the, I wouldn't say dictum, but accepted philosophy of many centers that para-aortic node positive is as good or as bad as metastatic disease, so no surgery. But so that means you are kind of making a change there.
Standard is recommendation is these are metastatic, but we have seen if these are good risk patient, they definitely prolong survival in our experience. They are after response, after seeing the biology of the tumor, they are responding, and these patients do well.
Response is with CT alone or with PET?
With the PET also, we do PET CT as well as CT, PET CT with triple. Response is metabolic activity as well as size should come down, and even if there is no progression, that is also a sign of response.
So we are clearly segregating one subgroup of stage 4 patient indirectly. We are saying that this group of stage 4 patient, there is role for surgery.
I think
indirectly we are saying that.
AGCC 6 and 7, this used to be M1A disease. They were not clubbed out with a disseminated disease. So I think that is that previously it used to be segregated between M1A and M1B. Still it remains the primary chemotherapy.
For chemo. So are you trying to define a subset of oligometastatic disease?
Yeah, I think it is a we have published our experience. This is not a prospective. These are very selected. That is why next step should be that once we do a new prospective neoadjuvant trial, then this will be one subgroup of patients. But in our experience, they have a reasonable better survival as patient as compared to patient in which we have not operated.
Survival may be due to only due to better tumor biology.
That is why. That is all the neoadjuvant chemotherapy. If you see from pancreatic cancer, all the neoadjuvant chemotherapy is only helping in select good risk patients, good biology of the patients. This is the basic.
Good biology patient should have, one group should have surgery, one group should not have surgery, then we should follow, and then we should have result, and then we should say key.
That is right.
What you are saying is the ideal, but in the absence of that, whatever evidence we have that.
Sir, my point is we should define guidelines on the basis of evidence available.
Yeah, as I said in
I think
these are not guidelines because there is no evidence. Evidence is not strong
Dr. Nag,
to say that these are.
there are a lot of data from Japanese and Korean studies. They have also shown even in Aretxabala the survival is better in T4 and N2 disease. All these data have shown at least 20% 5-year survival they have shown in a Japanese study also.
No, I think we have to discuss from the standpoint of what we are aiming at in today's meeting, this meeting. So if we are trying to make some consensus, then see, for every cancer we are trying to extend the boundaries. We all know that even in T4 advanced age, there are subset of patients who will do well. So by giving neoadjuvant, by waiting, you are just trying to define the biology better. It's not that neoadjuvant is a game changer. I personally feel that after going through all the literature of so many cancers, there are very few cancers where neoadjuvant actually has shown to help per se. It is basically you are trying to define the biology better. Those who respond to neoadjuvant are actually better biology. So this is a small subset. I don't think we can just publish a recommendation for this small subset. We should have a publication absolutely agreed. Japanese have published, they've been publishing for years about those advanced cases which the Westerners said that they are unresectable and you should not resect. So the philosophy is different between the East and West regarding the outcomes of surgery. But I would say that once we are talking about making a not guideline, even if consensus, and it's for
I
people
think
who are
this
sitting
setup is only
everywhere,
for
not in a-
increased discussion between among the peers
Yes.
so that we can move forward to what should be
I
necessary.
think it's good, but if we are trying to make a consensus on something, then we should stick to broad topics. We cannot change the world in this single meeting. Okay, go ahead and do, if you find a parietic note, it becomes very confusing.
That is why at present we can't recommend.
Yes.
But in selected group.
You
we
can
have been
publish, you
doing,
can publish
but we
anything
can't
these days.
recommend at present.
In every cancer, all metastatic cancers don't die within that 3-month period. That's why they always put a range 3 years to 1 year.
Responding to neoadjuvant, only that subgroup is going to benefit.
Sir,
Yeah, sir, so one more comment about the chemotherapy part. Like in the CA breast colon, it has made significant difference, neoadjuvant chemotherapy. Same thing about the GB cancers, like yet the molecular biomarkers which will be guiding us for the neoadjuvant and adjuvant therapy is yet very much in progress. Even vaccine is also being attempted. So if we are able to identify certain biomarker, then biomarker driven treatment including immunotherapy may be useful in particular subset of patient. And again agreed that all patients with GB cancer do not respond to neoadjuvant chemotherapy. It is ultimately the surgeon's decision and surgeon's domain for GB cancer to treat.
so the last question of discussion of the this is. So last one thing I want to include in this discussion, irrespective of the stage of the disease, if we get to know the patient has a bile leak intraoperatively, so can we defer these patients for reoperation or re-resection irrespective of the T stage? House is open for you are agree or not. Should we go for surgery or should we not go for surgery? Okay, so from our discussion, we know mainly the contraindication of the reoperation is we know like one of the discussion of the intra-aortocaval lymph node positive, the matter of debate is here. But the question was the LVI, PNI and the grade 3 tumors is still the debate is there, should we go or not. So we have discussed many things. Yes.
In the south it was fairly common and they had the best prognosis, the papillary tumors. So they will not have a margin positive, but for instance they will need a bile duct resection. So those were the, I think probably of the long-term survivors, the largest group cohort was from the papillary tumors. Even, although it wasn't all that common, but those are the ones which had, so whether we should be having any, sort of recommendation for papillary tumors.
Usually not associated with stones. It is the tumor which is more frequently seen in the Japanese series. It has less propensity to metastasize to lymph nodes, but it has more propensity to have multifocal or multicentric origin. That is why CBD resection is recommended by some Japanese groups. And yes, they have better prognosis.
So we've had recurrences even after 15 years also.
In papillary tumor, if you haven't done a CBD resection, many groups recommend that even if otherwise not indicated, you should give adjuvant chemotherapy.
The last one more contradictory thing was there, sir. Cyst duct margin was positive, CBD was resected, but there is no difference in survival. Should we go for resection or not? Yes or no? So yes, should we go for resection or what the house says for this? If the CBD is cystic duct margin positive, should we go for CBD resection or not? One of the paper was showing that